In this lecture video, I will discuss about approach to sensory ataxia. Physiology of equilibrium include the visual impulse from retina and proprioceptions from ocular muscles, labyrinthine inputs which senses the change in velocity of motions and positions of the body, and proprioceptions of the joint and muscles of the neck. These impulses are sent to the cerebellum and brain stem structures which maintains the equilibrium of our body. The signs and symptoms in ataxia include ataxia with retinitis pigmentosa. The etiology could be Rifson's disease or mitochondrial disorders. Ataxia with retinal or macular degenerations, ACA7 or aceruloplasminemia, that is spinocerebellar ataxia 7, optic atrophy and visual loss with multiple sclerosis or Friedreich's ataxia, square wave jerks in Friedreich ataxia, oculomotor apraxia in ataxia telangiectasia, slow saccades in ACA2 and 7, dawn-beating nystagmus in ACA6, and anti-GAD ataxia. Ataxia with focal and lateralized brainstem deficits is seen with posterior circulation strokes, papilledema and headache with posterior fossa tremors, internuclear ophthalmoplegia with posterior circulation strokes as well as MS. Vessel ganglionic deficits with ACA 1, 2, 12 and 6, 17, tremors with 12 and 15. Deafness with mitochondrial disorders, myoclonus, palatal myoclonus, cognitive decline, psychiatric features and autonomic features, these can all be associated with ataxia. Then ataxia with neuropathy, the etiology could be Friedreich ataxia, Fragile X syndrome, vitamin E deficiency, anti-gliadin ataxia, SCA2, 3, 4 and 12, as well as Rifson's disease. Ataxia with dementia, the causes could be anti-gliadin ataxia, steroid responsive ataxia, HIV and AIDS, mitochondrial disorders and amyloidosis. Ataxia with seizures, anti-GAD, anti-gliadins, mitochondrial ataxia, episodic ataxia 2 and 4, CZD and steroid responsives. The test for ataxia, sensory ataxia include proprioceptions. To test for proprioceptions, which is defined by awareness of position and movements of our limbs, finger and toes, it includes two modalities, that is sense of position and sense of movements. Normally, a very slight degree of movement is appreciated in digits, that is 1 degree of arc, and rapid movements are more easily detected than slow ones. Other clinical tests for ataxia, sensory ataxia include pseudoathetosis, which is piano playing movements, that is when patient has its arms outstretched and eye closed, the affected arm will wander from its original position. That is called as pseudoathetosis, which can be seen in this figure. Then other tests for sensory ataxia includes Romberg sign. In this case, ask the patient to stand with heel closed together, first with eye open and then with eye closed. And we can see that excessive postural swing or loss of balance, when it is present with both eye open or eye closed, then likely etiology could be cerebellar deficits seen in cerebellar ataxia. But when this swaying or postural imbalance is exaggerated, when the patient closes his eyes, then the etiology could be proprioceptive deficits, which is seen with sensory ataxia, and this test is called as Romberg's test, and we can say that the Romberg's is positive. Then test for vibrations. Vibrations and position sense are usually lost together, but one of them may be affected. With advancing age, vibration is the sensation most commonly diminished, especially at toes and ankles. The clinical difference between different types of ataxia, first is sensory versus cerebellar. In sensory ataxia, nystagmus is absent, dysarthria is absent, and eye movements are sometimes abnormal. In Chenomard disease, finger nose taste are present and worsen with eye closure. Whereas cerebellar ataxia, nystagmus, dysarthria, which is nystagmus is present, dysarthria is scanning or scatter speech, eye movements are normal to slow, and finger nose ataxia is present. With these we can distinguish sensory from cerebellar. Apart from it, heels in ataxia is present and worsen with eye closure in sensory ataxia. DTR is absent and may be present, joint position is impaired, pseudo-athetosis is present, and exteroceptive sensation are reduced. These include joint position, vibration, proprioceptions. Wherein cerebellar ataxia, heels in ataxia is present, deep tendon reflex, pendular jerk is seen, joint position, pseudoathetosis, these are all up. Pseudoathetosis is not seen, joint position is normal, and exteroceptive sensation are normal in cerebellar ataxia, which is also called as motor ataxia. Apart from it, Romberg's test is positive. Gait is high stepping gaits, whereas in cerebellar ataxia, Romberg's is negative and the gaits are broad-based and staggering gaits, that is clumsy, wide waist, similar to the gait seen in acute alcoholism, and patient will not able to walk straight, and patient with gait have truncal instability during walking. The difference between vestibular and cerebellar ataxia, the patient with cerebellar ataxia will present with the sense of imbalance, post pointing in ipsilateral limbs, gaze evoked nystagmus, scanning speech, intention tremors, dysdiadokinesia, rebound phenomena, hypotonia, and pendular reflexes. The features of cerebellar deficit will be present, whereas these deficits will be absent in vestibular ataxia, and these nystagmus will be in the direction of nystagmus will be away from the lesions. The post pointing will be absent, and these patients will present with vertigo and with associated tinnitus and hearing loss. How to differentiate cerebellar from frontal lobe disorders? The cerebellar ataxia, the patient will be wide waist with variable velocity, irregular and lurching, with heels in taste will be abnormal, initiations will be normal, turning will be unsteady, postural imbalance will be present but not as that of frontal lobe disorders. Fall will be the late event, whereas in frontal lobe disorders the gait it will also present with the wide waist gait with slow to start with, short and shuffling, whereas in cerebellar there will be irregular and lurching gaits. Heel sign will be normal, they will initiation will be, they will start with a hesitancy, and turns while turning they will have hesitancy with multiple steps. Postural instability will be marked with frequent fall. These are the features of frontal lobe disorders, the gait changes in the frontal lobe disorders. Then, what are the criteria to diagnose clinically that it is a case of sensory ataxia? That is ataxia confirmed by clinical examination, which include finger-nose incoordinations or heel to ataxia or broad-based ataxic gaits. Number 1. Number 2, two or more of the following, that is Romberg's sign should be positive, that is worsen with eye closure, or there should be history of wash-washed phenomena. Number 2, that is pseudoathetosis and or impaired joint positions or vibration sense. And number 3, absence of nystagmus and cerebellar speech, cerebellar dysarthria, that is a scanning or a scatter speech. That is ataxia confirmed with clinical examination and two of the following, which include Romberg sign, pseudoathetosis or absence of nystagmus or cerebellar signs. Then we can classify it as a probable, clinically probable sensory ataxia. Then the disease of sensory ataxia include pathology can be likely in the proprioceptive systems anywhere in the lesions from peripheral sensory nerves to dorsal root ganglions to sensory nerves root to dorsal column of the spinal cord to the medial lemniscus of the brainstem to the parietal cortex. And the lesions anywhere in this pathway, the patient will present with sensory ataxia, and dorsal root ganglions are the most often pathology in the sensory ataxia. That means dorsal root ganglions are most commonly affected. The disease for sensory ataxia at the level of peripheral nerves, that is secondary to peripheral neuropathies, these patients will present with paresthesia, tingling or pseudocramps, symmetrical distal sensory loss, areflexia or hyporeflexia. Weakness, if present, is symmetrical, and when neuropathy is primarily demyelinating rather than axonal, paresthesia is early features. These are the features that the patient of sensory ataxia will present if the etiology is at the level of peripheral nerves. The causes peripheral neuropathy presenting with sensory ataxia include, if the cause is acute, then Miller-Fisher syndrome, sensory variants of GVS, semisynthetic penicillin. Subacute causes include Lyme's disease, neurosarcoidosis. The chronic causes include CIDP, paraproteinemia, diabetes mellitus, celiac disease and vitamin E deficiency. These are the causes of sensory ataxia at the level of peripheral nerves. Then paraproteinemic neuropathy. These patients of paraproteinemic neuropathy, the causes include Waldenstrom's macroglobulinemia, that is lymphoplasmocyte malignancy producing IgM paraproteins, can present with sensory ataxia if IgM paraprotein shows anti-myelin associated glycoprotein activities, and present with neuropathy leading to sensory ataxia. Then CHENOMAT, that is chronic ataxia neuropathy, ophthalmoplegia, monoclonal IgM proteins, cold agglutinins and anti-diacylo antibodies. These are associated with anti-GQ1B and anti-diacyl antibodies which can present with sensory ataxia. Then diabetic neuropathy. These patients present with distal symmetrical polyneuropathy. Small fibers are usually first affected, leading to pain, burning sensation, impaired spinothalamic sensation and autonomic dysfunctions. Large fibers are affected later, thus develop paresthesia and gait imbalance because of the large fiber being affected, and impaired vibrations, joint positions and pressure sensation and loss of ankle reflexes can present at the late stage of the disease. Then mitochondrial neuropathies in the form of Sandoz, that is sensory ataxia, neuropathy, dysarthria and ophthalmoparesis. Rare triad is due to mutation of polymerase gamma or twinkling genes. As the clinical features include dysarthria, and this lead to confusion with cerebellar pathologies. Then the causes of sensory ataxia at the level of dorsal root ganglions include subacute causes include HIV and hepatitis C, a small cell lung carcinoma, pyridoxine intoxication, chemotherapeutic agents, thalidomide, organophosphates exposures, colonic carcinoma, neuroendocrine tumors. Chronic causes include Sjogren's syndromes and chronic active hepatitis. The dorsal root ganglionopathies frequently is associated with paraneoplastic disorders. These immune conditions like Sjogren's syndromes or toxic exposure to drugs like chemotherapeutic agents and pyridoxines, and it leads to degeneration of peripheral axons and central sensory projections to the dorsal columns. Unique features are non-length dependent sensory nerves degenerations, means dorsal root ganglionopathies will present with non-length dependent sensory nerves degenerations. These dorsal root ganglionopathies are asymmetrical, patchy. Neuropathic symptoms in the form of pain, burning, paresthesia and sensory loss with involvement of more involvement of the upper limbs, early sensory ataxia, areflexia and marked impairment in the proprioception, pseudoathetosis but relatively preserved muscle strength. These patients will present with the pseudoathetosis, marked proprioceptive deficits, areflexia with preserved muscle strength. NCV will show marked involvement of the sensory fiber with reduced or absent SNAPs in non-length dependent fashion. Paraneoplastic dorsal root ganglionopathies will present with subacute and rapidly progressive sensory ataxia and pain and paresthesia, most commonly associated with a small cell lung carcinoma. This subacute and rapidly progressive sensory ataxia, pain and paresthesia, most commonly associated with a small cell lung carcinoma, Hodgkin's lymphoma, neuroendocrine tumors, and breast and ovarian carcinoma. Then paraneoplastic dorsal root ganglionopathies can also be associated with anti-onconeural antibodies and may develop before the cancers being clinically detected, clinically examined or clinically apparent. Then paraneoplastic dorsal root ganglionopathies can be associated with anti-onconeural antibodies like anti-Hu and anti-amphiphysin, anti-coagulation collapsine responsive mediator proteins and CRMP5. Then the causes of sensory ataxia because of the involvement of sensory nerves root include chronic immune sensory polyradiculopathies. In this case, the patient will present with severe sensory loss with preserved sensory nerves action potentials. The chronic immune sensory polyradiculopathies is in this case there is involvement of large myelinated sensory nerves root proximal to the dorsal root ganglions, and they will be present with ataxia and limb paresthesia. On examination, sensory ataxia, areflexia, impaired joint position and vibrations sense with normal strength, and NCB will be normal, but somatosensory evoked potentials are abnormal, suggesting sensory nerve roots involvement. MRI may show enlarged and enhancing nerves root, CSF may show raised proteins, and sensory root biopsy may show demyelination similar to that of CIDP, and these are responsive to immunomodulators. The causes of sensory ataxia because of the involvement of posterior spinal columns include this patient will present with paresthesia in the form of tingling, pin and needle sensation or girdle-like or band-like sensation with loss of vibration and position sense below the level of lesions, and these may simulate a parietal cortical lesions but differ in the form of vibration sense is also lost in the spinal cord lesion. Thus, these are the features of if the patient present with sensory ataxia because of the etiology of dorsal columns or posterior spinal columns involvement. The causes include vitamin B12 deficiency, copper deficiency, tab dorsalis, HIV and hepatitis C, as well as cervical myelopathies. The patients with vitamin B12 deficiency will present with limb paresthesia, subacute gait disorders with sensory ataxia and spasticity. Examination will show the sign of dorsal column impairment, including loss of proprioception and vibrations, as well as combination of sensory ataxia and spastic paraparesis. And these are length dependent peripheral neuropathy coexist and may manifest as depressed lower limb reflex with stalking sensory loss. The tab dorsalis is seen with tertiary neurosyphilis. In this case, there is degeneration of posterior columns of the spinal cord and sensory nerves root. This patient will present with lancinating or lightning night pains with progressive sensory ataxia, proprioception loss and positive Romberg sign. Other causes of tab dorsalis include diabetes mellitus, vitamin B12 deficiency and other diseases that involve posterior roots and dorsal root ganglions can present with tab dorsalis. Then the DDs, the causes of sensory ataxia because of the involvement of thalamus, involvement of ventero-posterior lateral and ventero-posterior-medial nucleus of thalamus. These patients can also present with sensory ataxia, and usually the causes include vascular lesions as well as it can be also seen with tumors. The position sense is affected more frequently than other sensory functions. Then the causes of sensory ataxia with the involvement of parietal cortex, parietal lesions include, in these cases, the patient will present with loss of proprioceptive sensations or lack of a spatial orientations is due to destruction of parieto-pontine fibers designated for cerebellum, and this patient can occur without any sensory loss. Then the Inherited causes of sensory ataxia. In these cases, there is complete absence of SMAP with no positive sensory symptoms, strongly suggest the genetic causes. The causes include Friedreich ataxia, ataxia with vitamin E deficiency, A-beta lipoproteinemia, a spinocerebellar ataxia with neuropathy, and mitochondrial neuropathies. These are the inherited causes of sensory ataxia. In this case, there is complete absence of SMAP without any positive sensory symptoms. Then investigations while we are suspecting the sensory ataxia include cause specific or etiology specific investigations. If we are suspecting Miller-Fisher syndromes, then anti-GQ1B, CSF and nerve conduction studies, sensory variants of GBS, anti-gangliosides antibodies, Lamb's disease, if we are suspecting, then Lamb's serology, neurosarcoidosis, CSF, nerve conduction studies and ACE levels, CRDP, nerve conduction studies, paraproteinemia, electrophoresis and anti-MAG antibodies, diabetes mellitus, plasma glucose, celiac disease, anti-transglutaminase antibodies and vitamin E deficiency, we can look for vitamin E level. Apart from it, HIV with serology, paraneoplastic syndromes, different paraneoplastic antibodies, pyridoxine intoxication, history of exposures to the high pyridoxines levels, chemotherapeutic agents, the history we can suspect with the chemotherapeutic agents exposures, Sjogren's syndromes with ENA antibodies and liver biopsy, chronic active hepatitis, we can look for the hepatitis serology. Then vitamin B12, we can look for the vitamin B12 level, copper, we can look for it, tab dorsalis, syphilis serology and cervical myelopathy with neuroimaging, we can study with it. And the CRDP, chronic immune sensory polyneuropathy, we can look for the SSEP and CSF as well as nerve conduction studies. Thank you. Thank you for watching my lecture.